Hello everybody, and it's my great pleasure to continue our series of video lectures on electrolyte abnormalities, with today's topic being hypokalemia. Now, hypokalemia is defined as a serum potassium concentration below 3.5 milliequivalents per liter, and the normal serum concentration is 3.5 to 5 milliequivalents per liter. It is important to mention that more than 98% of our total body potassium is intracellular, and hypokalemia could be due to any of the following three mechanisms. The first being decreased oral intake, the second being increased translocation or shift into the cells, and the third one and the most common cause is increased losses of potassium, either through the GI or the urine or sweat. Now, it's very essential to denote that the potassium disorders are more significant than the sodium disorders in general because of the cardiac toxicity associated with the potassium disorders, and therefore potassium is said to be the most clinically significant electrolyte. So let's now move forward to the etiology of hypokalemia. And again, we have those three mechanisms. The first is decreased oral intake, the second is increased translocation to the cells, and the third and the most common one is increased loss of potassium. So let's first finish with the small categories and then move to the large one. So decreased oral intake is basically taking less than 40 milliequivalents daily. The normal daily intake is anywhere between 40 to 120 milliequivalents daily, and that's approximately equal to 1.6 to 4.8 grams daily. But it's actually quite uncommon to have an isolated decreased oral intake to cause hypokalemia, but it's usually superimposed on another cause, such as a diuretic therapy. So if a patient is on a diuretic plus he has decreased oral intake, then it would be significant. The second mechanism is increased translocation into the cells, and it could be due to a variety of different mechanisms, starting with exogenous insulin. Now, insulin increases the activity of sodium-potassium ATPase pump, and therefore when you give exogenous insulin, you'll have increased activity of this pump, and therefore more sodium kicked out of the cells and more potassium driven into the cells, particularly the skeletal muscle cells and the hepatic cells. Please note that the effect of hypokalemia is most predominant in the administration of insulin in patients with DKA or hyperosmolar hyperglycemic state, and that's because in these two conditions you already have a decreased total body potassium, and therefore when you give this insulin, what's left of the potassium will be translocated into the cells, and therefore a higher risk of developing hypokalemia. Now, coming to the second cause of increased potassium translocation into the cells, which is increased beta adrenergic activity, and basically we're talking about beta 2 agonists, whether it is exogenous by drugs or endogenous by the release of the catecholamines. Now, the beta 2 effect increases the potassium translocation into the cells by three proposed mechanisms. The first is increased sodium potassium ATPase activity. The second is increased sodium potassium 2 chloride cotransporter activity, and the third is possibly by increasing the release of insulin through the beta 2 receptors. So overall, the beta 2 agonist effect contributes to the hypokalemia. Now, our third mechanism is alkalosis, and what takes place in alkalosis is the increased activity of the hydrogen potassium ATPase in an attempt to buffer the alkalosis, so that more potassium is driven into the cells in exchange for the hydrogen ions pumped out of the cells in an attempt to buffer the pH. And now with the fourth cause, which is hypokalemic periodic paralysis, which is muscle paralysis induced by acute episodes of hypokalemia due to increased shift of potassium into the cells after certain triggers, such as rest after a heavy exercise, or a high carbohydrate meal, or fasting, or even stress. All of those can trigger hypokalemia in those patients. Now, this condition occurs in these patients either inherited as an autosomal dominant pattern or acquired as in patients with hyperthyroidism. Now, please note that these patients have a normal serum potassium concentration in between the acute episodes, and they have a normal potassium excretion rate by the kidneys. And now coming to our fifth cause, which is increased hematopoietic cell production, such as administration of B12 or folate in megaloblastic anemia to treat the anemia, or such as in giving colony stimulating factor in neutropenia, so any cause of increased hematopoietic cell production will shift the potassium into the cells to make the new cells. And then we have hypothermia. And the mechanism which is thought to produce hypokalemia and hypothermia is that in hypothermia you have increased activity of the beta adrenergic activity and therefore shifting potassium into the cells. That's why you should be extremely cautious when you are rewarming your patient, because you could have a severe rebound hyperkalemia causing fatal arrhythmias, and so one should be very careful during the rewarming process. And finally, we have the intoxication with certain substances such as barium, cesium, and chloroquine, with barium and cesium blocking the surface potassium channels and therefore blocking potassium from leaving the cells, and with chloroquine increasing the potassium shift into the cells. This is all for the increased translocation into the cells, and we could probably include one more point which is not mentioned here, which is if you have a patient with leukemia or leukocytosis and you leave the collected blood specimen at room temperature after the collection, this will induce hypokalemia in the blood sample. And to avoid hypokalemia in certain conditions after the blood collection is either you run the analysis very quickly or you save the specimen at 4 degrees Celsius before the blood analysis. And now finally let's proceed with our last category, which is increased losses of potassium. And we have 3 main routes again by which we could lose potassium. The first is GI losses, the second is through the urinary losses, and the third is sweating. So starting off with the GI losses, we could further classify it into upper GI losses and lower GI losses. Upper GI loss is basically vomiting and tube drainages such as NG tubes. So let's now have a look quickly at what really happens in vomiting. So in short, we have loss of water and the following ions: sodium, chloride, hydrogen, and potassium. Now it is important to mention here that the potassium loss directly through the vomitus is not very significant, but rather we have 2 other mechanisms by which they really trigger hypokalemia. The first is the water and the sodium loss will trigger aldosterone release in response to the dehydration, and one of the actions of aldosterone happens to be potassium excretion to the kidneys, so we get hypokalemia. The other mechanism is that you have metabolic alkalosis, the buildup of bicarbonate due to the loss of the hydrogen ions. And when you have a severe vomiting, the very high serum bicarbonate concentration and the high filtered bicarbonate load in the kidneys will exceed the renal bicarbonate reabsorption capacity, and therefore you will have more bicarbonate excreted in the urine. As this bicarbonate is a negative ion, it has to be accompanied by positive ions to maintain the electroneutrality, leading to loss of bicarbonate and sodium in the urine. But when this filter reaches the distal nephron, some of this sodium will be reabsorbed in exchange for the excretion of potassium, so that potassium is excreted, and therefore the end result, you will have more excretion of bicarbonate, sodium, and potassium in the urine. And this is the second mechanism by which leads to hypokalemia. Please note that this is not a complete description of what happens in vomiting. Hopefully in the metabolic alkalosis video we will explain vomiting in a more comprehensive way. Great, so let's get back to our original flowchart where we have reached lower GI losses, which includes diarrhea, villus adenoma, VIPoma, which is vasoactive intestinal peptide secreting tumor, Ogilvie syndrome, and geophagia. In a nutshell, all of those examples have increased potassium excretion through the lower GI tract, except for geophagia, which is clay ingestion, in which clay binds the potassium in the GI tract and therefore excreted through the tract. And now we move to the urinary losses. And we've got a variety of different mechanisms by which we could lose potassium through the urine, but I will hopefully try to explain it as simply as possible, starting with the diuretics. And all of the diuretics will cause increase in the potassium excretion through the urine, except for the potassium sparing diuretics, and simply because the potassium sparing diuretics act distally to the potassium excretion sites in the nephron. And the mechanism by which diuretics in general cause increased potassium excretion is via 2 ways. The first is the volume depletion induced by the diuretics will directly activate the renin-angiotensin-aldosterone system, and the end result would be increased potassium excretion. And the second mechanism is increase in the sodium delivery to the distal end at the potassium excretion site, and therefore more sodium exchange for potassium, resulting in more potassium excretion in the urine. That's all for the diuretics. And now moving to the increased mineralocorticoid activity, which is usually aldosterone aldosterone, and these patients are usually hypertensive, unlike all of the other causes. The third is non-absorbable anions, and these include bicarbonate as in vomiting, beta-hydroxybutyrate as in diabetic ketoacidosis, or in penicillin's administration. Now these anions, since they are non-absorbable, they will maintain a negative electrical potential in the lumen, and that's why when the filtrate or the load reaches the distal end of the nephron, there will be even more potassium exchange for sodium because you have a more negative potential, a more negative gradient across the membrane, and therefore you have more potassium loss. And our fourth cause, which is vomiting and tube drainage, is already explained previously in the upper GI losses, but I've also included it in here because the main mechanism is actually urinary, by which you have hypokalemia and vomiting and tube drainages. But since you also have to a small extent potassium loss in the vomitus itself and the gastric secretions, I've included it under the GI losses right here. And finally, we have a bunch of less common causes by which they cause hypokalemia, starting with polyuria. And generally speaking, any cause of polyuria has the potential to cause hypokalemia because simply you have an increased urine volume and therefore more electrolytes are excreted in the urine. The second is RTA, renal tubular acidosis, and only type 1, which is the distal RTA, and type 2, which is the proximal RTA, have the potential to cause hypokalemia. Nevertheless, hypokalemia is usually not seen in the lab reports because we have a coexisting acidosis in those patients, in the renal tubular acidosis. And when you have acidosis, you will have increased potassium shift out of the cells, which is the exact opposite of alkalosis. And therefore, the acidosis in RTA will mask the hypokalemia, which resulted from the increased potassium loss in the urine. And then coming to hypomagnesemia, and approximately 40% of hypokalemic patients also have a concurrent hypomagnesemia, and that's because there are lots of similar mechanisms that cause hypomagnesemia also cause hypokalemia, such as the diuretic use, the vomiting, the diarrhea, etc. But it is very important to mention that hypomagnesemia itself can cause hypokalemia, and it's not very certain how it does that, but there is a theory that hypomagnesemia increases the opening of the potassium channels in the kidneys and therefore more potassium loss in the urine. Consequently, it is very essential to treat the hypomagnesemia in order to treat the hypokalemia. And now going to the antifungal amphotericin B, which causes hypokalemia in up to 50% of the patients using it. And it causes hypokalemia by two mechanisms. The first is the amphotericin B inserts itself in the cell membrane, creating pores that increases the membrane permeability and therefore more potassium escaping the cells. And the second mechanism is that amphotericin B itself causes nephrotoxicity by inducing type 1, the distal RTA, resulting in hypokalemia. And then we have salt wasting nephropathies, in which there is a defect in sodium reabsorption and therefore more sodium delivered to the distal end of the nephron, resulting in more potassium being exchanged for the sodium and therefore more potassium lost in the urine, resulting in hypokalemia. And it could be due to a variety of different renal causes, such as tubulointerstitial diseases, as in interstitial nephritis, due to Sjogren's syndrome, or reflux nephropathy, or could be due to hypercalcemia, or even due to Barter's and Gitelman syndromes, both of which are considered by lots of people to be types of salt-wasting nephropathies. And now coming to the Barter's and Gitelman syndromes, both of which are autosomal recessive diseases, with Barter's syndrome mimicking the chronic use of a loop diuretic and Gitelman syndrome mimicking the chronic use of a thiazide diuretic. And therefore both will give a very similar picture of the chronic use of these two diuretics, and so both will have hypokalemia and metabolic alkalosis. And now with Liddle's syndrome, and Liddle's syndrome is an autosomal dominant disease where there is upregulation of the luminal epithelial sodium channels in the collecting tubule, resulting in more sodium reabsorption despite the suppression of aldosterone. And since you have upregulation of those channels, you will have more sodium reabsorbed, creating a negative electrical gradient in the lumen, promoting the secretion of potassium and hydrogen ions into the lumen of the collecting tubule, and therefore resulting in hypokalemia, metabolic alkalosis, and hypertension. Hypertension is due to the reabsorption of the sodium. And the bottom line is you'll have a very similar picture to primary hyperaldosteronism, which is Conn's syndrome, but the primary difference is that in Liddle syndrome, your aldosterone level will be reduced. And finally, we have the low-calorie diets, which are usually low-carb, high-protein diets intended to lose weight. But the mechanism of how you have increase of the urinary potassium loss is incompletely understood. However, there is one hypothesis that states because you have a low-carb diet, you are more likely to have periods of hypoglycemia and therefore ketogenesis. And with ketogenesis, you have the beta-hydroxybutyrate, which is a non-absorbable anion secreted in the urine, and once it reaches the distal nephron, it increases the potassium secretion into the lumen because of a higher electrical gradient difference, and therefore resulting in hypokalemia. And now finally, let's go to the sweat losses. Now, sweat itself doesn't really have a huge amount of potassium concentration. In fact, the potassium concentration is somewhere about 5 to 10 milliequivalents per liter, which is about the same as the potassium concentration present in the gastric secretions in the upper GI losses. But nevertheless, if you have a patient exercising in a hot climate, they could produce sweat volumes up to 10 liters or even more. With that substantial amount of sweat volume, you could have potassium depletion. Plus, there's another suggested mechanism is that in exercise, you have the release of catecholamines, and catecholamines will act on the beta-1 receptors in the kidneys, releasing renin, and therefore activation of the renin-angiotensin-aldosterone system, and finally more aldosterone excreting potassium in the urine. That's all for the mechanisms. In fact, there are two more mechanisms which I had no idea where to fit in the flowchart, so I've just put it here right in the top right corner, with the first being plasmapheresis. And plasmapheresis is separation of the plasma of the patient from the blood, disposing that plasma and replacing it with another fluid such as albumin or saline, or a mixture of albumin and saline, or even fresh frozen plasma. So if we replace the patient with albumin, there could be a transient hypokalemia due to the dilution of the blood the albumin causes. And the second one is dialysis. And in general, there are two proposed mechanisms by which hypokalemia can result in dialysis. The first is if you have a patient with end-stage renal disease and that patient is maintained on a chronic or maintenance dialysis, there could be excessive amounts of potassium lost in the dialysis, but it's unlikely to be isolated in itself, but rather superimposed on a decreased oral intake or on an increased losses of potassium as in the GI or in the urine. And that will manifest the hypokalemia. That's the first mechanism. The second mechanism in dialysis is that right in the pre-dialysis period, you will have to some extent a metabolic acidosis in the patient's serum because of the renal disease. But right after dialysis starts, there will be reversal of the metabolic acidosis, and therefore there will be shift of the potassium back into the cells upon the reversal of the metabolic acidosis by the hemodialysis. And this explains why despite the dialysate has more potassium concentration than the serum itself, we still have hypokalemia. And this is explained by the shift of the potassium back into the cells. And this is the second mechanism. This is all for the etiology of hypokalemia, and now let's go to the management of hypokalemia. And like all of our previous videos, management starts with the history taking, and beginning with the history taking, we assess the oral intake. Is there any decreased dietary potassium? We ask the patient of any vomiting, diarrhea, or the use of diuretics, or even the use of insulin or beta-2 agonists as in asthma, or intoxications as in barium or cesium, or any history of renal diseases, especially those causing salt-wasting nephropathies, or any recent history of sweating or the use of dialysis. And those points are just a few of a long list of things you should ask in history. And now let's move for the physical examination. And the first thing you do when you do the physical examination is to order an ECG. And in fact, the ECG should even be before the history taking. The first thing you should do is the ECG to exclude any life-threatening arrhythmias that could occur in hypokalemia, especially if the potassium level is below 3. Because when the potassium is between 3 and 3.5 milliequivalents per liter, it is unlikely to be symptomatic or problematic. But once it drops below 3, then symptoms start to manifest. And we have an example of an ECG on hypokalemia in here. The first thing we can see is the U wave, and then we have flattening or even inversion of the T wave as in here. We could also have prolongation of the QT interval. However, it is not really a true QT interval prolongation, but it's rather because of the fusion of the U wave to the T wave, it appears that the QT is prolongated, but it's rather the QU interval which is prolongated. So it's not really a true QT interval prolongation. And we have a few other ECG changes, such as ST depression and PR segment prolongation. So again, it is very important to do an ECG to pick up those changes because your treatment is different when you have ECG changes. And the chance of an arrhythmia in hypokalemia is higher if there is a concomitant coronary ischemia or hypomagnesemia or digoxin use or even the use of the beta agonists. Any of those factors will increase the risk of an arrhythmia in hypokalemia. So what is the mechanism exactly of an arrhythmia in hypokalemia? So let's quickly review the pathogenesis of what really happens in hypokalemia. So in short, what happens in the muscles is that when you have hypokalemia, the potassium outside the cells will be low, and therefore when depolarization happens, you will have lots of potassium leaving the cells to the outside because of a higher electrical gradient difference. And this results in hyperpolarization of the cell membrane, and therefore the resting membrane potential will be more negative, and this decreases the depolarization, causing weakness in the muscles. However, some parts of the cardiac conduction pathway, such as the Purkinje fibers, there are channels called K2P1 channels, which will start transporting sodium into the cell, causing depolarization. Now, these channels normally only transport potassium, but when hypokalemia occurs, they start to transport sodium into the cells, causing depolarization and therefore increasing the membrane excitability and arrhythmias. And there are one or two more mechanisms by which hypokalemia causes arrhythmias, but we're just mentioning the main one in here. Now going back to the physical examination, and the next thing we would do is cardiac auscultation, listening for any bradycardias, tachycardias, heart blocks, or any sort of arrhythmia. And then we assess the patient for dehydration, especially if the patient has a history of vomiting, diarrhea, or diuretic use. And then we test the muscle power, looking for any muscle weakness or paralysis. And then we perform an abdominal and a respiratory examination, looking for any ileus, abdominal distension, or diaphragmatic weakness or paralysis. And it's quite interesting that hypokalemia itself, when it causes weakness of the abdominal and the GI muscles, there will be ileus and abdominal distension, which could cause actually vomiting. And so vomiting can cause hypokalemia, and hypokalemia can cause vomiting. So it is essential when you see a patient with vomiting, you should still look for other causes of hypokalemia, excluding any other possibility. And of course we have the blood pressure measurement, which should be done early in the physical examination, which I have just added it right here, as it helps in categorizing your differentials. And now going for the investigations, starting with the 24 hours urinary potassium excretion, which is the most accurate test used to measure the excretion rate of potassium in the urine. But if you have a patient with severe hypokalemia, then you have an alternative of doing a spot urine potassium concentration or a spot urine potassium to creatinine ratio. Another test is called TTKG, transtubular potassium gradient, which pretty much gives us similar information to that of the 24 hours urine potassium, and it's used to confirm the results. And if your TTKG is above 7, that indicates renal causes, whereas if it's less than 3, that indicates extra-renal causes, such as the lower GI losses. And then we determine the acid-base status of the patient, as we have seen previously that some conditions occur with acidosis while others occur with alkalosis. And then we look at the serum magnesium level, as we have already explained that magnesium is very important, as hypomagnesemia occurs in 40% of hypokalemia, and that hypomagnesemia increases the risk of an arrhythmia with hypokalemia. And finally we'll look at the plasma renin and aldosterone levels. Of course, these are not all the investigations we would look at, but these are the most specific ones to hypokalemia. And finally, let's go to the treatment of hypokalemia. And the main modality of treatment is to treat the underlying cause of hypokalemia. We should of course replace the potassium lost, and we have many formulas for potassium supplements, but the most common ones used are the potassium bicarbonate, potassium phosphate, and potassium chloride, with potassium bicarbonate preferred in the metabolic acidosis patients, such as in diarrhea or in RTA, renal tubular acidosis, whereas potassium phosphate is preferred in those with hypokalemia and hypophosphatemia, as in type 2, the proximal RTA. And the last one is potassium chloride, which is actually the most commonly used form of potassium supplements for two reasons. The first one is that it replaces the chloride, which is commonly lost in hypokalemic patients due to diuretics or vomiting. And the second cause is that chloride is primarily an extracellular anion, unlike the bicarbonate, which is more intracellular to some extent than chloride. And this is an advantage for chloride because since it stays outside of the cells, it will be accompanied by more potassium in the extracellular space to maintain the electroneutrality, and therefore it is preferred for most of the causes of hypokalemia other than those that I've just mentioned for the potassium bicarbonate and the potassium phosphate. We can also give potassium sparing diuretics in severe patients to limit the potassium loss in the urine. It is very essential to ensure restoring of the magnesium if the magnesium is deficient. And finally, we have to be cautious in the treatment of redistributive hypokalemia to avoid hyperkalemia, and even put the patient on continuous ECG if required. And also, of course, you have to avoid hyperkalemia in general, especially in elderly, diabetic, and patients with decreased renal function, as they are more liable to have hyperkalemia as a complication. This is all for hypokalemia. Thank you very much guys for watching. I really wish that this has been an interesting video. Please feel free to ask any questions or if you have any comments to share. God bless you all.